Welcome everyone. I'm Dr. Grace Arenas from bioMérieux Medical Affairs, and it is my pleasure to introduce the chair of today's Pediatric Series webinar, Dr. Shuk Mesahel. Shuk is a consultant in pediatric emergency medicine and ED research at Alderhay Children's Hospital NHS Foundation Trust. She's also the NHR Northwest Coast Specialty Research Lead in Pediatric Trauma and Emergency Care, and she's also the Peruki Vice Chair. Shuk is keen to enable research in the pediatric emergency department through ED-generated projects and collaboration with other specialties. Other interests include developing and sustaining regional educational programs. Shuk is the PEDSIC BAFTA 2025 winner, and this extra from her nomination says it all. Her teaching sessions are consistently engaging and enjoyable, reflecting her passion for education. Dr. Mesahel is always keen to support juniors on the shop floor, providing top quality hands-on teaching and supervision. Her mentorship has been invaluable to many junior clinicians, fostering their growth and development. So welcome, Shuk. The floor is yours.
Thank you so much. Thank you for that wonderful introduction. It's a little bit embarrassing, and I didn't pay the trainee to say that at all. Welcome to the webinar. We've got a packed session for you this afternoon. I'm really looking forward to it. And I'm going to start by just saying a few words before we kick into the main session. So I work in the emergency department, and I know I've worked in the emergency department for approximately 20 years now. And throughout that time, there's been some huge changes in the way that we assess children, identify illnesses, diagnose them and treat them. And this webinar has got me thinking in terms of how have we made things better? Have these 20 years that certainly I've been working in pediatric emergency medicine and pediatrics in general, have we actually improved care? So pediatrics as a whole, emergency and urgent care is increasing. It's increasing worldwide, and we're seeing a lot more children present to emergency rooms. There's issues of overcrowding, there's issues of adverse events, and these tests that we have, these clinical pathways that we have we complicated matters outside of what we actually understand? Or have we made things streamlined? Have we made things better? How safe are we in terms of running our paediatric emergency departments and our paediatric wards? Technology has improved rapidly since I was a trainee. I remember RSV testing when I was a junior paediatric SHO taking 2 days to come back, and at that stage we could only test for RSV. It's quite interesting in seeing how all of that has actually come into clinical practice and how we're interpreting that and how we're moving forward. And hopefully this webinar can shed some light onto how we utilize these testings, how we can interpret them, how we can move forward, and what the future holds. So we are going to hear from experts in their fields about the current status of respiratory, bloodstream infections and orthopedic infections during this afternoon, and I'm really looking forward to it. And without further ado, I'm going to introduce our next speaker. Apologies, that's my phone going off. And I have the pleasure in introducing Professor Damien Rowland. He's a professor in paediatric emergency medicine at Leicester University Hospitals. He's an experienced paediatric emergency medicine clinician with considerable experience in development of educational resources and their evaluations, especially e-technologies. I'm going to go on. Damien is phenomenal. He has an international profile in the utilization of scoring systems to improve the recognition of ill and injured children in emergency and acute settings. The Paediatric Observation Priority Score was developed by Damien and is highlighted by the Intercollegiate Committee on the Standards of Care in Children and Young People in Emergency Settings. He has a really strong social media interest. If you're not following him, then you should. He'll put up his X account handle at the end of his presentation. He's got strong connections with both the Royal Colleges of Emergency Medicine and Paediatrics and Child Health, and he sits on the Paediatric Emergency Medicine Advisory Committee for both organisations. It just goes on and on. Welcome, Damien. The floor is yours.
Thanks, Shuk. I'm very embarrassed about that introduction now for you to read it out. You could have just said, Damien, he's a good egg. Let's move on. Good. Okay, so I think if I share my screen.
Just while you're setting that up, just to some housekeeping for our audiences. The video and your videos and your microphones won't be available. If you want to post any questions, then please post them in the question box, which is the little box with the question mark in it, and we'll get to your questions at the end of each session. Thank you.
Shuk, is it displaying?
Yes, it is. I can see it.
Cool.
It looks really good.
Brilliant.
I'm going to turn my camera off now. I'll also, if you are overrunning by 2 minutes, I'll come in and say hi.
Okay. That's brilliant. That's fantastic. Okay, so thank you all. As introduced, my name's Damien. I've had a long-standing interest in recognition of ill children, and I want to talk about sepsis, and I'm going to give you a case. Now, I wouldn't normally put this much text on a slide, but I get feedback sometimes that when I'm talking through cases, people do like to be able to see and read and remind themselves of what the case is. Simon's 11 months old. He's had a cold. He wakes up this morning. Mum is concerned. He's pale. He's a bit clingy. He's not quite right. He doesn't have any food, and he becomes a bit listless all of a sudden. So his mother calls an ambulance, and that ambulance brings him to the emergency department. In the emergency department, when he arrives, he's quite flushed, he's quiet, and he has a breathing rate of 42 breaths per minute with a heart rate of 165. There's no rash, but his hands and feet are reported to feel cold by the assessment nurse, and his temperature is 40.1 degrees. Now, he'd spat out the paracetamol his mum had tried to give him before they came to hospital. So what do you do with a case like this? This is extraordinarily common in emergency care. When we have a child who has some signs of illness, but as yet hasn't had any treatment. And this child can go in two directions. They can get some paracetamol, ibuprofen, look better and go home. They can also be sent home at any point during this journey and come back severely unwell. And I enjoy this quote from Mike Tyson, because it really does say to the fact that we have lots of kind of guidelines, procedures, but really the things that catch us out do catch us out. And a long time ago, a colleague of mine, Ed Snelson, who now works in Norwich, wrote about the fact that unfortunately there's lots of patients who present, and one of the pathways will be something that's quite benign, a self-limiting viral illness, and then the other could be something horrendous like group A strep. But the challenge of sepsis is this, and I love this from Don't Forget the Bubbles. Please do go on the Don't Forget the Bubbles website for all things kind of pediatric, especially acute and emergency care pediatrics. But everything's a virus really until it isn't, but it doesn't become obvious until it is obvious. And that has always been the challenge of sepsis in children. Ed Snelson runs a great website, and I love these list of things that make sepsis challenge. Sepsis does appear to just develop, and there's almost always something that puts you off, or puts you down the wrong route. Sepsis is very, very non-specific. But it's a real challenge, because if we look at all the children who present to emergency departments in the UK, there are about 4.3 million of them. Out of that 4.3 million of them, there are approximately 150 to 250 deaths from sepsis. Now, each of those deaths is an absolute tragedy. But those sepsis deaths represent an absolute minuscule proportion of the children presenting with what could potentially be sepsis. And so people use the needle in the haystack analogy all the time. It's probably overused, but it's true. This is a tiny proportion of what we see. And the problem is that a lot of illness, the most cases that present to the emergency department are inconsequential infections. That infection will get better of its own accord. That's a common cold. Meningococcal disease has a very low chance of presenting to your emergency department and is massively life-changing if you catch it, and if you mistreating it, it's catastrophic. So where do we decide to intervene on that line? And that is the real challenge. And this is exacerbated because the low incidence of disease protects those who aren't thinking about it. Now, this original quote was incompetent, and I think that's really harsh on healthcare professionals. But there are lots of people who do practice in a way that probably exposes them to risk. But because you might go through your whole career, and certainly if you're in primary care or a GP, it is very easy to have a whole career and you'll never see a child with a proper serious bacterial illness, such as meningitis. Is the inconsistent practice, you'll never get caught out. And we have another problem created because of the amount of children who present without serious disease, is that clinicians who are anxious, who become overwhelmed, who become cognitively overloaded, develop something called inattentional blindness. And to be fair, inattentional blindness can affect anyone. It's where that you're not seeing what's in front of you just because of the cognitive biases and the challenge you face. And then unfortunately, you miss a case and your performance is called into question. And that is a real shame. And I think one of the things that I've been really trying to advocate for is that some of our current guidance for sepsis really puts all the pressure on the clinician, and we unintentionally create pressure for clinicians, which causes them to perform badly, and then we falsely castigate them for missing something that actually they would never have going to have spotted in the first place. And the underlying challenges that we face in sepsis is, and you'll see I'm repeating some of the same points here, is there is this spectrum that no treatment will not result in harm for a large majority of cases because sepsis isn't present at all, and that there will be a number of cases where no treatment will result in harm because they definitely have sepsis and it's obvious. But where do we go in the middle? What is the equipoise for risks and benefits? We overtreat sepsis to the consequence of AMR, and we sometimes undertreat it with the consequences of harm to children. And that balance is incredibly difficult. And the reason why I've become frustrated with our current sepsis tools is that they're very one-sided and they are predicated on very specific clinical criteria. So this is, as of the moment, the current NICE, National Institute for Clinical Excellence, which operates in the UK. And what this says is if you're a child and you have a potential infection, i.e. you have a fever, or you might have clinical signs of something like an infection, which is the large majority of children presenting with a potential illness to an emergency department. And if you have a high respiratory rate or a heart rate above 160 if you're under 1 or 150 and 1 to 2, then you are deemed to be high risk criteria. And that if you don't choose not to treat that and that child gets sent home and you are subsequently found to have sepsis, then you will be penalized because you have not recognized that that child was high risk and you did nothing about it. And that, as it stands, is the current approach in the UK. Now, how does this play out in practice? Well, we've got a couple of studies, one I'm going to quote here, but there are at least 2 or 3 more which support this, is if you apply that NICE sepsis criteria to a cohort of children presenting to an emergency department, 40% of those children will meet that NICE red flag criteria. But if you look at the amount of children who actually have sepsis as defined by being admitted, demonstrating a blood culture or other non-sterile culture of an infectious organism, then it's less than 1%. Basically, you've got a 0.7% rate. So there is a complete mismatch between the incidence of sepsis as described by NICE sepsis and the actual outcome. And what that means is that you need to screen 256 patients, all of whom have red flag sepsis, to be able to find one patient who actually does have sepsis. And to really kind of double down on this, this is work we did from the CAPIT study. So CAPIT was a study looking at antibiotic duration and amount for a large cohort of children, over 880, who were diagnosed with pneumonia and sent home either from the ED or from the ward. And what you find is if you look at risk categories, respiratory or circulation hydration risk, 50% of children who were under 5 who were treated adequately with oral antibiotics met nice red flag criteria. And if I show that even more, we had 590 children from the ED who were discharged safely from the ED. There was no adverse outcomes in the CAPIT study. What we find is if we take both maximum risk categories, either respiratory or circulation, that 54% of those patients who were treated with oral antibiotics alone met nice red flag criteria. So to me, this screening criteria just cannot possibly be functional in the current climate. Now, this makes a real challenge, and I use this slide in a couple of presentations to talk about the cognitive work that all clinicians do in emergency departments. Thinking is difficult. Now, I'm not against guidelines, and they're there to provide cognitive prompts. They shouldn't really be decision-making aids. You shouldn't be told what to do, but they should aid your cognitive processes so you're not burdened all the time. They should provide simple guidance. And the problem with the guidance as it currently stands is that switch from when something is negative to when something is positive is not always clear. The example I often give is CRP. Is it different between 99 and 101? If you're seeing a 6-week-old with a fever, does it matter if that fever is 38.1 degrees or does it matter if it's 37.9 degrees? Now, from a guidelines perspective, 38.1 at 6 weeks means that you should be jumping up and down and giving this child antibiotics. Technically, 37.9 means that you shouldn't, but that's really odd, isn't it? Because actually a thermometer has a error rating of 0.3 degrees C. So basically 37.9 is 38.1, but up and down the country, that line will be used for treatment or not for treatment. And then we have a number of cognitive bias that come in at play here, is that when you're presented with a decision, action is always an easier thing to do than inaction. And this is why if you have guidelines with poor specificity, you're prompted to start using antibiotics in patient groups, which you probably don't need to, but you're worried that you might miss out. And there's good evidence of this. Time and time again, studies have shown that people like action over inaction, and that we know that action bias leads to clinically inappropriate patient expectations. So we treat antibiotics, we perpetuate the antibiotic myth, we admit patients to hospital when they don't need to be admitted, and so we drive consumer demand. And if you go back to my earlier slides, that means more and more patients are presenting for emergency care, so therefore making it even more difficult to find patients who do need treatment. And this is exemplified by, this is exacerbated by loss aversion. I like this. So this is a famous study where basically if you flip a dice and one of those wins you $10 and one of those loses you $10, people are much more concerned about losing $10 than they are winning. Now, in healthcare, that's right. You certainly do not want children to come to harm, but the impact of any harm that you do in healthcare completely outweighs any benefits of sometimes holding back. So we have this problem where we have guidance which over highlights when patient might have sepsis, and then we have a cognitive bias both through kind of action bias and loss aversion that makes us fall into the trap of unnecessarily treating. And what I want to finish with is the challenge of the future. So I've shown how difficult current sepsis screening guidelines are, so we need to replace those with something more impactful. But as we come into an age of AI and that we have wider spread decision making, what are we going to do when the reverse occurs? When you see a child who is completely well, but that AI algorithm tells them that you must treat with antibiotics, completely against your better judgment. And so I think we have a real developing problem now, is that we have current guidance that isn't working for us. And then we have future guidance, which is going to really challenge our decision-making processes. Now, what is the answer to this, you may ask? Well, the National Pews programme in the UK is starting a process of, rather than using internal physiological criteria, so just heart rate or respiratory rate, using, like we do in adults, a NPEWS banding. So it will only be if you have an NPEWS of 5 to 8 or 9+ would you be considered for a sepsis review, rather than a trigger that is solely based on a heart rate or a breathing rate. Now, unfortunately, I don't have any data to share with you on that, but that is the next step of this pathway of using scoring systems as a sepsis screening tool, rather than just specific physiological criteria, which is, I hope I've demonstrated, really have little value at all. And so I will finish there, Shruk.
Thank you so much, Damien. It's absolutely fascinating. I'm going to take that quote that Ed Snelson said, "It's not sepsis until it's so blindingly obvious that it was always sepsis." I think that's a great quote. Thank you so much. So what we're going to do is we're going to move on to the next presentation, then we're going to have the questions and answers at the end. Damien, there is a question for you in the chat if you want to have a little look at that
Cool.
while I'm presenting. Okay, so I'm going to share my screen now. Can people see my screen? Oh no, hold on, share. It's coming, it's coming. Okay, great. Can you see my screen?
Yes.
Lovely, thank you. Okay, so I'm going to talk about little babies' lungs in the emergency department and co-infections. And I'm going to touch upon, following on from Damien, it's quite a nice follow actually, talking about the clinical assessment of febrile children very briefly, literally mentioning by word clinical scoring tools, how and when to use point of care testing, and just trying to put that all together to maintain emergency department flow. That's my focus. So it follows on really quite nicely from Damien's talk about actually reaching a diagnosis is complex. In emergency departments, the quoted rate of patients who experience an adverse event is about 1 in 33 children. So in my department, that would mean that 6 children a day would have an adverse event, and that would mean something like a misdiagnosis or an inadvertent drug error. And when you talk about statistics, it's quite important to actually apply them to your setting, and to kind of say, well, 6 children a day, every day, for a year, for 2 years, that's an awful lot of children who we're not getting it quite right for. There's a high degree of overlap between serious infections and benign infections, and trying to differentiate the two is really quite challenging. Most children will come into present into the emergency departments with a low prevalence of serious disease. It's mostly viruses, but trying to distinguish between, as Damien had said, between finding that one sepsis case between bacterial and viral illnesses remains a particular challenge in the emergency departments. We know that antibiotic resistance worldwide is increasing, and we know from testing in COVID that the prevalence of co-infections, when we test somebody, prevalence of co-infections is higher than we thought, although the clinical relevance of the co-infections remain uncertain. And there's a balance between diagnostic certainty and the challenges that follow with maintaining patient flow. So moving on to clinical assessment. Well, clinical assessment is, fever is by far the highest presentation in numbers to paediatric emergency departments. And as usual, I'm not going to, you know, this is kind of teaching how to suck eggs. Have a standard approach, which has been taught since the beginning of time, the beginning of medicine. History, examination, look at the red flags, and think about your diagnostics, think about what interventions you want to do, and look at the disposition, what's going to happen to your patient. Immediate discharge, or an observation for a period of time, or direct admission, or community care. Any of those types of things will suffice. But in terms of kind of respiratory viruses, respiratory illnesses presenting as infections, well, there's a whole load of them, and I think trying to understand what infects children at what rates, well, it's the usual suspects. We know that it's rhinovirus, it's RSV, it's influenza, adenovirus, human metapneumovirus, and they're all shaking hands with each other. And you know, who's rhinovirus in these pictures and who's RSV? You know, trying to figure out whether it's just one virus or it's multiple viruses that are infecting. And so what does that mean? If it's just one virus, or is there a co-infection, so one virus plus other viruses or plus other bacteria? What does it mean for clinical presentation when you come to look at a child? So you don't know that this child has one virus or virus plus others. And so when you look at a child, there's some clinical features which will potentially point to children with co-infections being sicker than children with just a single virus. So this was from this was a national study from Romania, and they showed that in children who had co-infections, they presented with a more severe form of lower respiratory tract infection than children who presented with a single virus. So higher fever. They had more signs to find on examination. So they had chest signs, they had lower oxygenation, they had extra pulmonary issues, so vomiting, diarrheas, rashes, things like that. But again, still, we don't quite know what's in the box. We can see what it is. It's an infection. It's likely to be a respiratory in nature based on the presenting features, but we don't quite know what's inside it. What is there? Is it a virus by itself? Is it a virus plus other viruses? Is it virus plus bacteria? What does that mean for your patient, and how do we diagnose it? As Damien touched upon, there are multiple clinical scoring tools, and I think most of the presenters today will have an image like this to try and say, well, how do we pick out the one patient who is the patient who we need to do something about, and we need to do something about pretty much now. And clinical scoring tools, they make risk visible. There's triage, there's an assessment triangle, there's the traffic light system, and there's the national pews. And if you're wondering, there's a cat in the picture, and that's where the cat is. The NHS England, along with the Royal College of Paediatrics and Child Health and the Royal College of Nursing, have now rolled out the National Pews scoring tool. And they have 4 or 5 different assessment pages like this for each age group, and they're quite long, they're quite extensive, and they come out with a score, and with that score comes an action, and with that action needs a response. And this has just been rolled out. It's probably about 10 years in the making, and it's just been rolled out this year. So more interesting things to come from the data that this is going to result in. But my main focus of the talk is going to be about point of care testing, because that's coming in, and that's coming into an emergency department near you. And I'm going to specifically focus on point of care testing for respiratory illnesses. So there's 3 main groups of point of care testing. You have the rapid ones, which I'm sure you're all familiar with from the COVID pandemic. So these are antigen rapid testing. They are mainly immunoassays. They are like the lateral flow. They're quite fast, they're cheap, not very many, you don't need much training in them at all. In fact, these COVID tests were available to the public with like little pictures on them of how to do it. It's decentralized from the lab, and it's much less likely to detect in the post-infectious period. So while you're infectious, these are pretty good. The sensitivities are quoted at about 60 to 70%, and the specificities are about 90%. And you can run multiple tests simultaneously, and it has a runtime of about 10 minutes. So if you're using this kind of thing in the emergency departments on patients, then you can see how you can get a test result really quite easily without very much delay. However, there's better tests available and better technology available. So this is an example of the nucleic acid amplification tests. So this is PCR testing. The machine in the picture is an Abbott ID Now. In our emergency department, we have several of these. And they can run multiple tests at the same time. So there's one machine that we have, which is flu, RSV, and SARS-CoV. There's another machine that we have, which is a group A strep testing. And they're quite useful, but you can only run one sample at a time. So basically one patient at a time, and they take about 20 minutes to run. They're expensive if you look overall. So per test, it's probably about £25 per test, but the sensitivity is much better than the lateral flow testing or the immunoassay testing, and its sensitivity is probably about 90 to 95%. But if you have 4 patients in your emergency department or on your acute assessment ward that you want to test, one patient is going to take an hour for their test result to come back. Is that acceptable in your department? Is that acceptable wait when you've got another 20 patients booking in? It might not work as practically, it might not be as practically useful as you think, and then all of a sudden your costs start ramping up. The next phase of testing is something like this. This is the BioFire. This is a syndromic multiplex PCR testing. It's lab-based. This can't stay in the emergency department or on the ward. It's too big. It's a multiple panel test. Testing probably about 23 viruses and some bacteria at the same time. It's quite expensive. It's about £120 per test, but the sensitivity and specificity are absolutely brilliant. 97% and 99% respectively. But it takes 45 minutes to run, and it's again one sample per run. So if you have a patient in the emergency department and you want a result on this, it's going to take 45 minutes to come back, at least, by the time you take the test, transport it to the lab, run the test, and then the reporting. We're looking at an hour for each. Is that feasible in departments? And we know a lot more about kind of testing and against time and symptom onset with the antigen tests and the PCR tests now. A lot of work actually came out of COVID times for when they were testing and when people were infectious and things like that. And there's a few things that I want to highlight. So in this graph, so time is on the bottom and viral load is at the top, and there's a limited amount of time where the patient is actually symptomatic. There's a pre-symptomatic phase and there's a post-symptomatic phase. And the symptomatic phase is when they are unwell, when they have patients have a fever, a cough, they're feeling rotten. And that's when they present usually to healthcare. However, if you do a test before the symptoms become evident, then a PCR test will probably likely to be positive, but they're asymptomatic at that time. And again, after the symptoms have finished and the patient starts feeling okay and they're feeling better, if a PCR test is done then that might still flag up as being positive, but they're symptom free. So interpreting the test is really quite important. And if you have a winter like we had last year, so this is our data, this Alder Hayes data from 2024 to 2025. You can see the blue line at the top, that's jaggedy all the way across, that's rhinovirus. Towards the left of the picture, a nice big peak of red line, which is RSV, and then the grey line is influenza, etc., etc. So this was our viral picture last year, and you can see currently we have a lot of cases of rhinovirus and human metapneumoviruses coming in. So if you take a child in, kind of November last year, when rhinovirus, RSV, flu was rising, and you do a PCR on them, and they're this is all in the community, and you do a PCR on them, you think, okay, well, they're being exposed to these viruses one after the other, and you often hear that that message, don't you? They're always getting ill. The parents always say they're always getting ill. They had a fever last week, and now they've got a fever this week, and trying to kind of figure out what is causing their illness now. If I do a test then it might all be negative, but it won't actually indicate that you're not going to get an illness coming soon. If I do a test then and B, well, the patient would have just finished an illness. They might still be starting an illness, but I might have a result which shows that they are adenovirus and RSV positive. I don't quite know from that whether the RSV was from the old illness and the adenovirus is to come, or the other way around. So I don't quite know what I'm dealing with. And then at the end of all the illnesses, there still are PCRs that are positive. So interpretation in terms of the clinical context is really important. So there's something about diagnostic stewardship and about the right test being done for the right patient at the right time. Is the test appropriate for the clinical setting? So is the sensitivity and specificity appropriate? Is the cost appropriate for what you want to do? And is the diagnostic yield appropriate for managing your patients? Will the clinical care be affected for the patient as a result? So what's the clinical impact of doing this test? If I do a PCR test, which costs £125, or £120 on a patient who I'm going to send home who has RSV, is that clinically impactful? Probably not. Who am I going to do these tests on? What am I benchmarking it against? And what criteria? Do I have a guideline to follow? What criteria am I going to follow? And at the right time. So will the results be available in the time that will optimally affect care? So this is kind of centralization of devices versus point of care testing. This is demand versus batch testing. This is the run time and the specimen preparation time. Nobody in the emergency department is going to spin down a sample or anything like that at all. So how are we going to use these tests to guide flow, to get it right for the patient at the right time? We can't have patients waiting for hours on end in emergency departments for a test which might not make a clinical difference at the end of it. So there's something about overuse, and there's something about underuse. So overuse is when you're doing too many tests on people and they're not necessarily indicated. And what ends up happening is that you actually make diagnostic errors. There's an overdiagnosis, there's over-treatment of patients. If a patient had a positive influenza PCR, are you going to give them antivirals for that? Or actually, was that the PCR from last week and they're already over it? There's adverse patients' outcomes that are affected with overuse, and it's a waste of finite health resources in our current climate. Underuse, however, is a really big deal. Diagnostic errors, delay in diagnosis, delay in effective treatment, leading on to further healthcare costs. That patient has to come back to pick up the prescription. Oh, look, they're so much worse now. They require admission, as opposed to being able to manage their illness when it was reasonable. Now, we know that with viral co-infections, patients tend to be worse. So RSV tends to cause a more severe illness than any other type of viruses. we know that when RSV and human metapneumovirus shake hands, that causes patients at risk of a 10-fold increase to intensive care units. We know that RSV and rhinovirus, it's all RSV, isn't it? When they have a co-infection, they're reported to have longer stays in hospital. Influenza also, when it's combined with adenovirus and when it's combined with RSV, can result in very similar results. So these patients tend to be a bit sicker. And from recent observational studies, it's been reported that positive viral swabs, which are associated with less invasive bacterial infections in infants by approximately 60 to 70%. So if there is a patient, if there is a young febrile infant who is 60 or 90 days of, under 60 or 90 days of age, and they have a positive viral swab, they are less likely to have an invasive bacterial infection than patients who are negative for viral swabbing. But there's really wide confidence intervals in all of these studies that have been reported. And I don't think I'm brave enough at this moment in time to be able to say, right, the respiratory PCR in this febrile 50-day-old baby is because of RSV. I don't think I'm brave enough to do that yet, because the PCR testing and the testing that we do is only looking at what it's looking at. It's not actually looking at any other type of illness. It's just literally what it's listed on the test. And in terms of respiratory PCR management, well, has it changed our management? Well, in part it has, but there's still a lot more work to do if respiratory PCR testing by itself is going to change management. So it increases more timely antivirals for influenza. A combination of PCR with a procalcitonin-based algorithm might improve antibiotic stewardship. A combination of PCRs plus educational interventions might help improve antibiotic stewardship. And putting this into a decision support tool with electronic patient records can reduce antibiotic use. Now, this is all kind of focused on antibiotic use as opposed to kind of, kind of patient, other types of patient management. And that's all kind of what it's looking at the moment. And so there's something about antibiotic stewardship. Can respiratory PCR testing affect antibiotic stewardship? Well, for antibiotic stewardship to happen, it has to there needs to be a right interpretation. Will the clinician understand the results? Are they going to be reported in a way that the clinician can actually understand? And what helps with that is that if there's real-time decision support. So we need another clinician, we need a microbiologist or an ID clinician on the other end of the phone to be able to help us interpret what that result is saying. Will the clinician modify antimicrobials based on the results? Well, again, that could be linked into clinical practice guidelines. It might be linked into kind of assessment of the child on the ward based on things like Pew scoring or other types of testing. And will the clinician act promptly on the test? Well, there's no point in a test coming and nobody looks at it. And in a busy emergency department, we can't keep coming back to the computer to try and refresh the results, to try and look at the results when there's, there's a whole load of other things that we need to do. So is somebody going to call the results through? How are they going to be highlighted on the system? And actually, are we looking at it in the right way? We're looking outwardly. We're looking to kind of say what is coming in to invade the body, but actually, should we be looking at the body itself? And there's some phenomenal work by looking at host response diagnostics. The Diamond studies, the Perform studies, they are brilliant pieces of work which hopefully will actually change what we do. And it's not about the rise of the beasts, it's about the rise of the omics. And they Perform has looked at biomarkers, and one paper reported that actually there are some protein signatures which can differentiate the host response from if it's a virus infecting to if it's a bacterial infecting. And they've identified 6 protein signatures, 3 in bacteria and 3 in viruses, that have distinct expression in patients, and you're able to actually test for these. There are some panels which now look at what RNA transcriptions are, looking at specific etiologies. So the RNA transcriptions, when they've grouped them all together and they've looked at them, they can categorize them in 18 separate categories. So one category is bacterial, one category is viral, one's malarial, TB, inflammatory, so even non-infective. And so there's the body's response and what the body is doing, which can actually signal what is actually happening and what it's being invaded by. And then there's severity. So there's a fantastic paper in the Lancet that looks at the prediction of not only can these gene signatures, these 10 gene signatures, identify the infective organism type, so virus or bacteria, but it can also predict organ dysfunction within 24 hours of the test. So are we looking, are we looking in the wrong kind of direction, or do we need to look at both? But for me as an emergency medicine physician, I'm not going to run a 10 gene signature on a patient. I'm not going to look at RNA transcriptions. I'm not going to be looking at all of this kind of stuff. So how do we make this in practice? Well, there are machines coming. There are machines coming. This is one type of machine. This is the MeMed BV machine, which looks at 3 biomarkers. It puts those 3 biomarkers, those results, put into a computerized algorithm, and it gives out a score out of 100. So 0 to 35, if the score is in that's virus. 35 to 65, it doesn't know, and 65 to 100, it's more likely to be bacterial. And it's bacterial or co-infection with a bacterium. It's got a 15-minute turnaround time. It sits in the emergency department, but there are some caveats with that. It needs venous blood. It can't work on capillary blood at the moment, and it's quite an expensive machine. So the machine itself is quite expensive, and each cartridge to use, again, it's single patient cartridge. Each cartridge to use is expensive to use as well. And this we're using this in our emergency department at the moment, and this is the type of printout that it has. So this is on one patient who had meningococcal meningitis, and it had a score. This patient came back with a score of 82. This was even before we'd given antibiotics, so we knew that we had to give antibiotics. So putting it all together, so reaching a diagnosis could get easier. Use of triage, use of Pew's tools, the clinical assessments, point of care, diagnostics, biomarkers, and then early antibiotic use or de-escalation, escalation, as we know. So this is my last slide. So tiny lungs are sicker with co-infections, but we'll hear a little bit later from Jordan about respiratory viral infections may actually be associated with reduced invasive bacterial infections. We can't take one aspect and only do it by itself. We have to look at the whole picture. So biomarkers and testing are not a substitute for clinical acumen. We have to use it all together, and probably the best use is a combination of all of that with antimicrobial stewardship. And remember that actually it's the host response diagnostics that are coming. So thank you very much.